So working on the quads, this area is easy to work on, similar in a lot of ways to the hamstrings. Obviously it can be a very tender area, so talk to your patient. The fifth metacarpal head is one of my favorite tools, so I like to use that. If you don't remember your quads, there are 4 of them, hence the name quads, although there's actually a 5th one they've added now. If you want to find out about that, you can come to my anatomy class in October. But the quinces now, yes. Nobody calls them that. But I do like to kind of break down and work the anterior aspect of the lateralis first. So I'm working just in front of where that IT band thickness is. Then I'll come up and I'll work on the rectus femoris right in the center. You're technically working over the intermedius as well, but it's deep to rectus femoris. I like to stabilize the patella while I do this. All of the quads pull on the patella. It's a sesamoid bone and it's in the quad tendon. So I like to hold that down while I push up. Just let me know if I dig too much. Remember that rectus femoris is the only quad that crosses the hip, and it goes all the way up to grab onto the AIS. If I can remember my acronyms. Anterior, inferior iliac spine. So when I switch over to work medialis, I tend to switch hands, so I can work vastus medialis here. Just scream before you kick. If you prefer to pull down on the leg, some people like to do that more than push. Your pip joints are fair game here. Just, again, be gentle. So just dragging down. Remember, we pull with the pips to prevent our extensor digitorum from getting overworked. So we can work the lateral, the midline, come in here and work on medialis. Easy enough. You can do some grasping, that 4 fingers to 4 fingers kind of grasping, and if you find anything in particular that needs a little work, that's certainly an option. This area right at the top corner here is common to find problems. If I'm seated, then I'll do just like I did with gastroc, hooking, coming underneath. If I'm standing, then I tend to flip that hand over to push up, but your mileage may vary. The pisiform is also a wonderful tool in this area, so I can situate it right on that taut band and use static pressure. You can do press and release. You can do the gliding, whether you're going down or up. Any of that's fair game. If I'm going away from the kneecap, I like to keep that hand on the knee. Clunk. Not too painful.
That was right on the edge that last pass.
Yeah. There's a taunt section right in there. Moving over it needs a little work. If I were going to spend more time on that as a treatment, that's where I would break out my elbows. So let me know if I get too aggressive here. Of course, we can do our jostle.
That's probably it.
Right at the edge. I'll back off just. If it's feeling too pointy, you can drop down on the arm a little bit and use that ulnar blade to do a little work, although that can still be fairly intense in the quad, so just be gentle. You can also use the ulnar blade going the other direction here with it rather than across the leg. That's fair game too. I tend to find a ton of trigger points in the distal portion here of vastus lateralis, so we're in front of the IT band, right in this corner, and those often I'll work with the elbow, just gently leaning in, pressing straight down towards the femur. There are some little bundles of muscle that you probably didn't learn about in school. They're some of my favorite knee muscles, called the Articularis genu, or genus Articularis, depending on who you talk to. They radiate out from above the kneecap along this anterior portion of the femur, and they're unique muscles. They don't pull bone on bone. So they come off the femur, but they don't grab another bone. They don't attach to the patella. Instead, they grab the synovial membrane around the knee joint. When you straighten your knee, as the tibia rotates its way around the femur, it has a chance of pinching that synovial membrane between the two bones. And when that happens, it's very painful and can lead to joint inflammation and irritation. And so we have these little muscles that every single time we straighten our knee, fire to lift the synovial membrane in the front as that tibia rolls around so that you don't pinch it. And in some people, they get inhibited and they don't fire, and they have sharp pain when they step on an extended or straight knee, which is the characteristic symptom of a meniscal tear as well. And so the doctors will often say, oh, you must have a meniscal tear. And I've had a few patients who we've done all the orthopedic tests and they're negative for a meniscal tear, and they've gone in and said, you know, I'm having this knee pain, and the doctor has done an MRI and said, no, there's nothing in here that looks conclusive like that would be your problem. But we've treated Articularis genus with, in my case, usually E-stim, but body work as well. And when that muscle wakes up, they stop having that pain. So it's one to pay attention to. For manual therapy, usually I'm just working directly above the kneecap. I'm finding that superior edge, and you're just applying pressure straight down towards the femur. It can be a really tender area, but you know, you want to work as deep as their body will let you. And then you kind of work the corners off of either side of the patella, just pushing straight in.
And what are those muscles called?
Articularis genu, so G-E-N-U. Sometimes they reverse it and it'll be genus Articularis, so G-E-N-U-S, and then Articularis, which is spelled just the way it sounds. I can write it out if I need to. I always think it sounds like a punk band or something. But
I think I saw them play in the 90s.
right up there with the tensor fascia latte you got from the Starbucks. There's a video somewhere of Ellen DeGeneres sent an intern to Starbucks to order a tensor fascia latte. It doesn't actually end up being very funny though, because they just give them a random latte. They don't actually get confused or anything. So, working on the quads, fifth metacarpal, pip joints, elbow, all that's fair game. Come down and work on those articularis genu muscles if you would like. I spend a fair bit of time working with the kneecap itself, particularly if somebody has arthritis or chondromalacia, and I like to use the pisiform. Do you have that? Good deal. Well, let me know if this feels good or strange. It's sort of 50-50. Most people, when there's arthritis or chondromalacia, it feels really amazing to have the kneecap mobilized and worked on, but sometimes people say it just feels a little strange. Basically, I'm going to park my pisiforms on either side of the patella. So I'm going to cup the patella with my hands, and I'm going to just gently push the patella superior and then inferior, back and forth. Not too bad.
Yeah.
Does it feel good or does it feel weird?
It's not weird. It is nice to be mobilized.
You're like, I didn't know you did that to people's knees. I also will mobilize the kneecap lateral and medial. Depending on how bent or straight the knee is, you get more or less movement, but I'm basically just pulling it one way, pushing it the other. A little click out of it there. It's not relevant necessarily to a class about avoiding thumb use, but I like to pick the kneecap up and try to jostle it. That's a little more thumb intensive than officially we should be doing in this class. But, you know, you may love it. So, we threw it in there. In the lower part of the leg, there's not a ton of things to work. We have basically this anterior and lateral compartment, which you treat essentially the same exact way. It's kind of a small area relative. Tibialis anterior and the extensor digitorum longus are the big ones that people injure in this anterior compartment. And I tend to like my pisiform for this area. I can press in just distal to the base of the tibia here, apply that pressure and work my way down. If you have somebody with shin splints, somebody who's taken up running, their shins hurt, tibialis anterior is trying to rip itself off the bone, and you want it to be less tense. Working it can be useful.
Exactly what shin splints feel like too.
It's for a good reason. It's what it is. You can also work this area with the elbow. Same kind of thing. I tend to hook it into that palm. Gently apply that pressure. Let me know if it's too much, Bernie.
Not touching me yet, are you?
Or are you calling him out?
No, seriously, when he started, I could barely feel it.
Well, that's okay.
Yeah.
It can be as heavy or as light as you want it to be.
Would you ever have them actively engage and point towards the flex and flex?
You certainly can. I'm more likely to try to get them to relax and let me move it if I want to move it. So I might come in and press in with the blade of this ulna, stretch it out while I'm coming down, or shorten it while I'm coming down. But I am a big proponent of teaching them how to move and stretch, and they can do that on their own time and not pay me once I've taught them how to do it. Just get in there and work. Working the peroneus longus on the side, which is the major muscle of this lateral compartment that gets injured, can be done supine or prone because it's directly on the side of the body. And all of the stuff we've already been talking about fits in here. That fifth metacarpal head can be reached in to work, just stabilizing the leg with one hand, pressing in, either with static pressure or dragging that knuckle along. Pisiform can certainly be used, although I tend to push up with that if I'm working with the pisiform. If I'm pulling down, I tend to use more of the pip joints and just drag those down this way. Peroneus longus is one of the ones injured commonly when you have a inversion ankle roll, which is the most common way to injure the ankle, because you roll it this way and overstretch the peroneals, which you may have learned as fibularis, depending on when you went to school and where. Simple enough. Work down the front of the leg, and we'll go from there.